We are live now, we can start.
Shall we start, Sakshat?
No, we can wait for just 2-3 minutes. We are expecting Dr. Aparna Jaiswal to connect.
Okay.
Brijesh will wait for 2-3 minutes more.
Okay, sure.
Hello, hi. Good evening, Dr. Aparna.
Good evening. Am I audible to you?
Yeah, you are audible, ma'am.
Wonderful.
And good evening, Dr. Ritu.
Good evening. Good evening.
Good evening, Dr. Rudrani. Neeraj, are we going to wait for a few minutes or can we start?
Dr. Mustafa, we are expecting Dr. Hemarath to join because she's having the first session.
Okay.
So I guess we shouldn't wait. Maybe for next 2 minutes we'll wait and then we'll start.
Okay, fine. A warm good evening from Dr. Reddy's. First of all, I would like to begin this session. I would like to wish all the panelists, moderators, and the doctors who have joined this session a warm Happy Women's Day. This session is initiated under Diastology, which is the platform that we have created for having a scientific discussions and programs involving cardiology and heart failure. So this is the first session which is being conducted under this Diastology platform, and we are happy to have this first session where we will be discussing the women and the cardiac health. To begin the session, I would first like to introduce both the moderators, who is Dr. Aparna and Dr. Ritu, for a warm welcome from Dr. Reddy's. So I'll just try to project the slides. So today we have Dr. Aparna, who is the moderator for the first session of this program. I would request Sakshat if you can project the slides, introduction slides. Is it visible?
No, not yet. Yeah, now it's visible, Mustafa. Now.
Yeah. Thank you. So today we have with us Dr. Aparna Jaiswal, who is currently a director cardiology at the Fortis Escort Heart Institute, New Delhi. She has a glorious academic journey and is a gold medal during her graduation and super specialization. She is trained in electrophysiology at the St. Luke's Medical Center, Milwaukee. She further was certified with the IBHRE as a device specialist in 2007 and recertified in 2017. She have a keen interest in implantation of the cardiac devices and the ablation of arrhythmias. Of particular interest among arrhythmias is the ablation of the ventricular arrhythmias. She is actively involved in the management of patients of heart failure and atrial fibrillation. And Dr. Jaiswal has been mentoring young electrophysiologists for past several years and have been actively involved in IHRS and serves as a broad member for IBHRE USA. A warm welcome to Dr. Aparna Jaiswal for this session on women and cardiac health. We also have today Dr. Ritu Bhatia, who is a DM cardiology with 19 years of experience in the medical practice. She is a senior consultant interventional cardiologist at the Vadia Hospital, Pune, a teacher for DNB cardiology in Jahangir Hospital since 2014, an honorable assistant professor of cardiology in BJMC and SGH since April 2012. She has pioneered several pediatric cardiac procedures in new setups. She has experience of setting up and streamlining working of cath labs during the training of staff. She has experience of conducting outreach programs in rural areas and CMVs for doctors, has membership for various societies and associations, attended various national and international conferences. Welcome to you, Dr. Ritu Bhatia, for this session. So now I would like to hand over to Dr. Aparna Jaiswal, who will be giving a brief about the program, and invite Dr. Rudrani for her first session of the program. Over to you, Dr. Aparna.
Thank you so much, Dr. Mujtaba and Dr. Reddy's for having taken on this special day. I'd like to welcome my co-moderator and the other speakers for this special program. You may wonder where I am right now. It's very interesting that International Women's Day has suddenly had so much of a momentum in the past few years that we are enjoying what's happening, not because we are getting empowered, but because I think the set is being staged for gender equality in whatever best mannerisms that we can manage. And just a little historical perspective, I think I was reading up as to why do we celebrate? Because it's been suddenly, I think my fellow panelists will agree, in the past few years, we have seen that this has really caught the momentum. However, it's been around for over a decade, for over a century now. It was in 1917 that this actually came into being, and the UN commemorated 8th of March to be celebrated as the International Women's Day. Today, I think what Dr. Reddy is doing is very worthy of a mention. We are here trying to speak on something which is very dear to all of us as cardiologists. Women as a gender have been neglected for cardiac illnesses because it is always believed that cardiac illnesses is a man's disease. We have learned over the years it is not so. It is time that we brought our focus back, and without coming in between the program and you, I would like to invite the first speaker to talk about the session today. And I'd also like to compliment Dr. Reddy's for having given this special name of Diastology. I think a lot of momentum has taken forward about HFpEF and the importance of HFpEF in women. So I think I leave it for Dr. Rudrani. She's going to cover something which is so important, that is peripartum cardiomyopathy. Before I invite her, I think I'd just like to make a mention, and as women, we all understand that a woman has to undergo a lot more than the male counterparts, especially when it comes to changes in the hormones, be it menarche, be it pregnancy, be it menopause. So I think it's important we touch upon all of this. Over to Dr. Rudrani on peripartum cardiomyopathy.
Thank you, Aparna ma'am. First of all, my best wishes to everyone on International Women's Day. In my setting, my video is not working. So I shall be just doing my audio from here.
That's fine, Dr. Rudrani.
My screen is visible?
Yeah, it's visible. It's visible.
Okay, okay. Coming to the topic of peripartum cardiomyopathy, potentially life-threatening pregnancy-associated disease that typically arises in the peripartum period and is marked by left ventricular systolic dysfunction and heart failure. It's relatively uncommon, but there are certain hotspots which I shall be discussing in further slides. Its incidence is constantly rising. Women often recover cardiac functions, but long-lasting morbidity and mortality are not so infrequent. Now coming to the definition, a standard definition has been given by both European Society of Cardiology and American Society. It's an idiopathic cardiomyopathy frequently presenting with heart failure, secondary to LV systolic dysfunction, where ejection fraction has been taken in guidelines to be less than 45%, towards the end of pregnancy or in the consecutive months following delivery, that is in the postpartum, if no other cause of heart failure is found. If we summarize the definition, then it's a form of systolic heart failure affecting young women towards the end of pregnancy or in the months following delivery. Basically, peripartum cardiomyopathy is very much guided by the racial background of females. That is, it is very much higher in African American women with older maternal age, hypertensive disorders, and multiple gestations. Basically, symptoms of heart failure mimic those of normal pregnancy, and this often results in a delay in diagnosis, and this delay in diagnosis can lead to complications later on, which I shall be discussing in coming slides. Etiology is poorly understood. There are many mechanisms which has been given as a cause of cardiomyopathy, in a pregnant lady, like immunological response from the fetal antigen. Then a few studies have given a basis for familial clustering, indicating a genetic etiology. Then there is also a vascular dysfunction theory, which has been given as it has been seen that in the late gestational there is maternal hormone response, and this in turn leads to prolactin being broken down, and this causes vasculotoxic effects on the cardiomyocytes. This in turn when combined with genetic factors and environmental factors, further causes the damage to the cardiomyocytes. Genetic studies have identified variants in Titin gene, and there are many other genes like desmosomes gene, intercalated disc genes, and autophagy BAG3 genes, which have been proposed, and this in turn has led to two-hit hypothesis. That is, basically pregnancy in itself is a cardiac stress condition, and when this cardiac stress condition is being dysregulated by the hormonal changes in late pregnancy and in early postpartum, as well as the combined genetic and environmental factor, this all in turn leads to a vasculotoxic condition in the cardiomyocytes, leading to autophagy and damage. Coming to etiology, its incidence is very much varying if we see the geographical areas all over the world. The incidence varies somewhere from 1 in 1,000 live births in Africa and Asia to 1 in 300 in Haiti, and even 1 in 100 in Nigeria. Basically, these two places are referred as hotspots for peripartum cardiomyopathy. The incidence in US varies from 1 in 1,000 to 1 in 4,000. We can just make a impression from this that it is not an uncommon condition. Few risk factors have been proposed, like African ancestry, preeclampsia, hypertension, multifetal, that is multigestational pregnancies, and old maternal age, which all contributes to PPCN. These are again a short summary of the risk factors: increasing maternal age, multigestation, associated substance abuse during pregnancy like alcohol, then certain nutritional deficiencies like selenium, accompanying anemia, diabetes, obesity, and long-term tocolytic therapy with beta agonist too contributes to PPCM. This is a diagram very beautifully representing what actually happens during late pregnancy and during early postpartum period. Basically, the cardiomyocytes have got these two genes, STAT3 and PGC1 alpha. When these two genes are being knocked out, it has been seen that this in turn leads to an increased oxidative stress in the form of reactive oxygen species being formed. This in turn activates cathepsin D, which in turn during late pregnancy, as prolactin is being secreted in late pregnancy, prolactin is being secreted late pregnancy, and this in turn breaks down because of this cathepsin into 16 kilodalton prolactin, and this in turn acts on the endothelium of the vasculature and causes dysfunction and apoptosis. This is how the prolactin, which is secreted in the late pregnancy and preparing for the fetus and the parturition, is being broken down, and this in turn leads to endothelial dysfunction. It has also been proposed that there is another factor referred as SFLT1. This is tyrosine-like kinase protein 1, which in turn inhibits the angiogenic factors. And this in turn, when these factors which promotes angiogenesis are being inhibited by tyrosine kinase like 1 molecules, this in turn itself leads to endothelial dysfunctions. Therefore, from this we can also make an impression that miRNA 146A, SFLT1, these are the novel biomarkers which I shall be discussing, which can tell us the peripartum cardiomyopathy diagnosis as well as the prognosis. Now, we all know that in second trimester, the cardiac output and all hemodynamic stress of pregnancy are maximum, and still the incidence of peripartum cardiomyopathy is maximum just before your delivery, and 4 to 6 weeks postpartum, because it is at this we can make from these two peaks that it is at this level that these two prolactin 1 and SFLT1, these levels are maximum at 1 to 4 weeks postpartum, and this is when the damage to the cardiomyocytes are maximum. It is rarely seen before 36 weeks of gestation. Affected patient usually present 4 to 5 months postpartum. Severe LV systolic dysfunction well observed. Basically, I have already told that in definition there should be absence of a cause for the heart failure. Generally, we are not very well sure about absence of the cause, because not every pregnant female is going for a routine echocardiography of the heart. Diagnosis often delayed as symptoms over. This is very important. The diagnosis is often delayed as symptoms overlap those of normal pregnancy. Now, coming to diagnosis making, the most and foremost is a simple ECG, which is very safe in pregnancy. Here we see sinus tachycardia, non-specific STT wave abnormalities, voltage abnormalities, Q waves in anterior precordial leads, left bundle branch blocks, PR and QT intervals may be prolonged. And when they are prolonged, they carry a poor prognosis in these patients. When chest X-ray generally should be avoided, but if it is done, it shows cardiac enlargement and pulmonary venous congestion. Foremost is echocardiography, where we can see here left ventricle dilatation along with left atrial dilatation. There may be functional MR, TR. Right ventricle may or may not be dilated, but it may or may not be associated with right ventricular dysfunction. And if it is associated with RV dysfunction, it carries a poor prognosis for the female. Here at the apex, we may or may not get a left ventricle thrombus, because these segments generally gets akinetic. Biomarkers, as there is no specific diagnostic biomarker, we are very much dependent on routine biomarkers which we do in heart failures, like BNP, NT-proBNP, and troponin. But a recently biomarker MIR, these are microRNAs, which I have already told in the previous slide, and that FLT1, these may serve as novel biomarkers in peripartum cardiomyopathy, as these levels are negligible or almost nil in normal pregnancy. Endomyocardial biopsy remains very much unclear, but still its role cannot be disregarded. We can go for viral titers like Coxsackie-B, but generally not very much informative. Predictors of adverse outcome is always a low ejection fraction, generally less than 30%. If we have African ancestry, then accompanying obesity, anemia, preeclampsia, LV dilatation, RV dysfunction, if accompanying LV dysfunction also, and LV thrombus. It is associated with higher recovery rates compared to other forms of heart failure occurring as late as 2 years. That is very important. That is, peripartum cardiomyopathy may show improvements even up to 2 years. Therefore, follow-up of these patients is very important. This is differential diagnosis of heart failure during pregnancy. First and foremost is Tachycardia cardiomyopathy. Generally, this is seen in postmenopausal females. And here we will see apical hypokinesia with basal hyperkinesia. And the ECG changes may be having ST elevations, which may not be corresponding to the any coronary artery territory. Then we can have familial cardiomyopathy, preeclampsia, hypertrophic, these myocarditis, LV non-compaction, valvular heart disease. All these can be differentiated very easily on the echocardiographic findings. Basically, echocardiography is the mainstay of investigation in these patients. Now coming to management part, as it is a multidisciplinary approach involving an obstetrician, a cardiologist, and an anesthesiologist. Therefore, what I want to emphasize here is that it is a multidisciplinary involvement of very much fraternities that will lead to a successful pregnancy and its outcome. We have to be very careful regarding the fetal safety, as all drugs cannot be given during pregnancy. During pregnancy and lactation, loop diuretics, beta blockers, digoxin, hydrazine nitrates can be very much safely used. We all know ARBs, ARNIs, aldosterone, even MRAs, they are all contraindicated during pregnancy as they have high fetal toxicity. What American guidelines guide us about anticoagulation during pregnancy is that if ejection fraction is less than 30%, patient is at very high risk of developing venous thrombosis. Therefore, anticoagulation is must if ejection fraction is less than 30 and till 6 to 8 weeks postpartum. Warfarin is contraindicated, as we all know. Warfarin is highly embryotoxic, but low molecular weight heparin and heparin can be safely used. The data on NOACs are very little. Therefore, during pregnancy, till data become more robust about NOACs, it should be avoided. The role of bromocriptine as therapeutic agent is currently experimental, as many small studies has been done, and therefore bromocriptine is being now given 2B classification to be used in peripartum cardiomyopathy. Just because clinicians in their practices have used, and there is a common consensus among clinicians, therefore bromocriptine is just 2B classification to be used for peripartum cardiomyopathy to suppress lactation. And whenever bromocriptine is used, as it is prothrombogenic, therefore anticoagulation has to be given. Now a fast review for treatment. If a patient presents to us with acute decompensated heart failure, then we have to manage according to the HFrEF guidelines. The management we do for HFrEF patients, the standard guidelines like using oxygen, diuretics, dilators, antiarrhythmics, inotropics, anticoagulation are normally used. Then because there is small trials regarding use of immunoglobulins, and in certain trials it was found to be beneficial, but no robust randomized controlled trial are available for use of bromocriptine or for IVIG for acute treatment of PPCM. Regarding chronic treatments, again RAS blockers, as now patient can be taken on RAS blockers, beta blockers as they are now safe. Therefore, we can start using these drugs also. CRT, ICT, cardiac transplantation. For these three, we have to be very much clear regarding the guidelines, because this peripartum cardiomyopathy generally improves in around about 50% of cases in next 6 months. Therefore, we have to be very cautious regarding whether putting these patients on ICDs. Wearable cardioverter defibrillators are encouraged, but not a permanent ICD till we are 100% sure that this PPCM is not improving with our best guideline-directed medical therapy. These are a short summary of drugs that are safe in pregnancy. We all know loop diuretics can be given, beta blockers, especially metoprolol tartrate has been preferred, hydrazine, digoxin, they're all safe. ACE, aldosterone, ARNIs, they are all fetotoxic, should not be given. Ibuprofen data is very less. Regarding anticoagulants, warfarin should be avoided. Low molecular weight heparin or heparin can be used. When we are towards the lactation period, that is postpartum, then we can use ACE ARBs also if the risk-benefit ratio is more towards the benefit for the patient. Even MRAs like spironolactones can be used during lactation. Regarding the principles of management, I will just summarize from the previous slides that cardiac transplantation, if not responding to all the maximum guideline medical directed therapy for at least 6 months, can be done, but generally it is associated with higher rejection rates because of allo antigens and lower survival also seen. Prolactin has been implicated in the pathogenesis. Therefore, 2010 European guidelines advise against breastfeeding. But since we are living in a developing country, therefore it's totally the obstetrician's decision to see for the mother and the infant outcome. Therefore, in certain registries in United States, breastfeeding is found to be safe. Still, it is a very dilemma-like situation whether to continue breastfeeding or not. Contraception should be discussed as soon as feasible, and estrogen, because it is prothrombogenic, the contraceptions containing estrogen should be avoided. Progesterone releasing implants or intrauterine devices are encouraged. Regarding the time, till what time we should continue the therapy for these patients. As I've already said, 50% patients recover their LV functions. For more than 50-55% by 6 months postpartum of continuous guideline directed medical therapy. Still, if LV dysfunction persists, medication should be continued indefinitely. In those with recovery, data are very, very limited whether to go for indefinite or to stop. For this, if we are planning to stop as patient is improving, it should be a very stepwise manner. First of all, we should withdraw slowly diuretics, and then other guideline medical therapy should be slowly withdrawn with continuous clinical and echocardiographic monitoring of the patient, because the chance of relapse in these patients are quite high. Around about 15-20% patients again take a relapse, and again they are put on GDMT. Women who recover to EF more than 50% still have an increased risk for heart failure, and therefore appropriate counseling has to be given to these patients regarding additional pregnancies. And if they plan, then serial clinical assessment along with BNP levels, along with echo, should be done to assess the pregnancy throughout till delivery. This is standard treatment. As we all know, the treatment for heart failure, non-pharmacological, pharmacological, with salt restriction, water restriction has to be done. As pregnancy itself retains a lot of water, the water restriction has to be done. Then regarding pharmacological, we all know about these drugs. Anticoagulation, as we know, hypercoagulation itself in pregnancy occurs. Stasis of blood in left ventricle occurs. Pregnancy itself leads to a procoagulant stage. Therefore, we have to anticoagulate the patient postpartum also.
Dr. Rudrani, sorry to interrupt. I think we are exceeding on time. If you can quickly summarize.
Okay. Fine. I have discussed about immunosuppressive agents. IVIGs can be given, but their role is still not proven. Cardiac transplantation already discussed. This is how the serial monitoring during a subsequent pregnancy is done. Counseling and management of subsequent pregnancies already discussed. Future pregnancies, patient has to be totally on monitoring from the cardiologist and gynecologist side. Then 5 things to know about. The symptoms we all know of HFrEF. Patient will present with symptoms of heart failure with reduced ejection fraction. Echocardiography is gold standard. Treatment I have already said. If recovery occurs, the ejection fraction will normalize to greater than 50%, often within 3 to 6 months of diagnosis. But 5-year mortality rate is not very less. It is about 20% even in a developed country like United States. And if the ejection fraction doesn't recover to more than 50%, then next subsequent pregnancy should be discouraged. To summarize, medication used to treat heart failure during pregnancy and lactation requires special consideration. Advanced therapy, mechanical circulatory support may be used. There is always a risk of relapse in subsequent pregnancies. Dedicated counseling and monitoring is very essential. Future research about long-term outcomes, continued drug therapy, use of bromocriptine device, and genetics are further needed. Thank you.
Thanks, Dr. Rudrani, for that informative session. It's quite relevant with the problem having high mortality and morbidity, and then increasing incidence of the problem and the limited treatment options. This problem requires a high effective management as newer therapies for the management. With that, I would like to now invite Dr. Himarath for her session on, she is an intervention cardiologist who will be speaking on the women and the coronary artery disease. Over to Dr. Himarath.
Am I audible to you, please?
Yes, yes.
Yeah,
Am I
doctor.
audible? Yeah.
Yeah,
I'm
doctor.
not
You are
able to
audible.
show the video. I don't know. This video is not starting.
It's okay, ma'am. Even if you can just project your presentation, that's fine. Even if the video is not.
Okay. I'll just start. Is the video not working? She's scared. Where is my screen? Are my is my slides
Yeah,
visible?
no, ma'am. Your slides are
No.
not coming. Your video is on. You can share screen, ma'am. Yeah. Now it's coming.
It's visible?
Now it's
Yes.
now it's visible. Yeah.
I'll enlarge it. Okay. Can you see it, please? Hello?
Yeah, we can see it. We can see
Yeah.
it, ma'am.
Yeah, I'm really sorry. I had some technical issues to join my screen here. I'm Dr. Hema Rath. I'll be speaking on women and coronary artery disease. Let's start with, before starting, I would wish all the women a very happy Women's Day, International Women's Day. And the topic for today's discussion, I'll start, is heart disease in women, especially coronary heart disease in women. We know that heart disease is the #1 killer disease of the woman. 1 out of 3 women but you die every 80 seconds. It takes more life than all cancers combined. 90% of the women have 1 or more risk factors for developing heart disease. Why do 2 or 3 men die out of heart disease? 2 to 3 women die due to heart disease who have no warning signs at all. So let's see the magnitude of cardiovascular disease in women. Overall, cardiovascular disease still remains the #1 cause of death. Although there is awareness about cardiovascular disease, a present threat to the health of the woman is due to a part of prevalent traditional risk factors, which we all know is the obesity, hyperlipidemia, diabetes mellitus, and hypertension as such. But why women are more having an extra risk factor is the pregnancy associated conditions such as gestational diabetes, hypertension, preeclampsia are now the recognized additional risk factor for development of CVD. These variable highlights the importance of providing this prevention of coronary artery disease, and a topic of discussion for today. Let's see a global trend in the last few years in Denmark. The data from Denmark, Israel, and Japan is showing a reduction in the mortality rates of this coronary vascular disease in women. Why is it due to? The deaths from coronary vascular disease have decreased over past 3 decades. So women in many parts of the world still have worst outcome after acute coronary artery disease, but evidence of sex-related disparities in acute coronary syndromes emerged over 30 years ago already. How did it start? In the very earlier days, they started recognizing in way back in 2003 that the heart disease in women is coming a biggest worry. It was a front cover page in the way back in 2003. So what is the statistics? It is almost averages with that of the Indian. That is 1 in 3 coronary artery disease occurred in men and females, and 1 in 31 is the cause of death for breast cancers. How is it different from that of the male? The traditional risk factors in females are the same as that of the male. That is the diabetes, smoking, obesity, overweight, physical inactivity, hypertension, dyslipidemia. But what is more important is additional risk factors which we have in women are the pregnancy related issues, having a preterm delivery, the hypertensive disorders in pregnancy, that is the preeclampsia, the gestational diabetes, the autoimmune disease, the breast cancer treatment, breast cancer for which the treatment they receive, and more so the depression, the psychosocial depression which most of the women in all over world they experience this kind of a problem, for which they have an additional risk factors to get a coronary artery disease. So what exactly there is a change in the male and a female incidence of this. That is the common traditional risk factors compared to male. The female gender are older than that of the male. How about the depression and psychosocial stress which they undergo? That is the the males are comparatively less psychosocially stressed or depressed than that of a female in the general population. That is more so in a younger age group. Hypertension, most women who are having ACS are having an hypertension. Smoking, though men and women smoke equally if at all, the harm produced by the smoking in female are much more than that of the male, especially in the age group of less than 45 years. Whatsoever about the diabetes patients, female patients are much more affected with the diabetes than that of a male. Overall, diabetes have 5% more risk factors than the more incidence of getting a coronary artery disease from the normal patients, but women have an edge over it. And obesity, more so, the women have a higher obesity range, especially in the abdominal region compared to that of the male. The chronic kidney disease is also found to be raised. Women have higher rates than men of traditional risk factors such as diabetes, hypertension, obesity, and a differential lifestyle and a psychosocial determinant. What extra do the risk involved? The specific sex-related risk factors are the pregnancy. Women in peripartum period have subsequent increased risk of MI from spontaneous coronary artery dissection. In the menopause, the incidence of acute MI rises sharply after menopause. Oral contraceptive therapies also have an additional extra chances of the females getting coronary artery disease. The diabetes mellitus, as I told, it is causes the six-fold greater risk of a female getting a coronary artery disease. What's the classification of risks in women? High risk, who are called as high risk. Clinical manifested established coronary artery disease, cardiovascular disease. Clinically manifested cerebrovascular disease, a peripheral artery disease, an abdominal aortic aneurysm, end-stage CKD, diabetes, and a AVSD risk of greater than 10% are considered high risk. And who are the patients are at risk? They are females smoking cigarette, systolic blood pressure of greater than 120, diastolic greater than 80, total cholesterol, obesity, poor diet, physical inactivity, a history of premature coronary artery disease, and years of and the evidence of atherosclerosis, having a coronary calcification, coronary carotid plaque, thickened intimomedial thickness, poor exercise capacity, and other autoimmune disorders like SLE, rheumatoid arthritis, psoriasis are all the additional risk factors in women who are prone to get a coronary artery disease. History of preeclampsia, gestational diabetes, and PIH, as I told, are the other risk factors associated with female having a coronary artery disease. Hello? 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 कुछ नहीं सुनाई दे रहा है.
Yeah, you are audible, ma'am. You are audible. Please continue.
Okay. The baseline risk factors for which I just mentioned here, it is shown in the Interheart study. Also that females are 4 to 3 times more prone to get coronary artery disease with the patients having diabetes, and also with the patients having obesity aged less than 55 years. Cardiovascular disease mortality trend, if we see we can see that there was a falling trend in between, started falling trend after the 1990. So what is the reason for this falling trend of mortality in females? And what is exactly the mechanism of coronary artery disease in females? We'll see a comprehensive study showing pathophysiology of coronary artery disease in women. They have the vasculopathy in women is somewhat different and more severe compared to that of men. Atherosclerosis is more or less extensive, and acute events are more frequent due to plaque erosion rather than plaque rupture. Structurally, the coronary artery themselves are of a smaller caliber in women compared to that of a man. What is it? The thrombus form, usually any MI is most commonly followed by a plaque eruption and a thrombus formation. So which is much less likely compared to that of a female, which have a more of eroded plaque causing a thrombus. What other things? The coronary vasospasm because of the addicted behavior or upcoming change in the lifestyle. The spontaneous coronary artery dissection, as I told you, it's more common in post-pregnancy, and that is also a cause for an MI in females. Stress-related cardiomyopathies, they also cause a similar look-alike feature of an MI. A substantial proportion of acute coronary syndrome cases in women are mainly by the reasons other than the plaque rupture, that is the erosion and then the thrombus formation. Plaque erosion, coronary vasospasm, spontaneous coronary artery dissection, and stress-related cardiomyopathies are more prevalent in women than that of the men. There are many case reports in which spontaneous coronary artery dissection causing intramural hematoma in young women having ST elevated MI, and it is not the plaque rupture event always in women. When did it all come into picture? By the first scientific statement from AHA in the year 2016, where they exactly studied the presentation, the pathophysiological mechanism, and the outcomes in the patients with acute myocardial infarction. So this first scientific statement of AHA on acute myocardial infarction involving the woman was released in circulation. So how do they present? Once there is a scientific statement which showed there is a delay in presentation of any woman having an MI or a ACS. The reason for the greatest delay in presentation of women than in men include there is a lack of awareness, misinterpretation of the symptoms there, barrier to assess the care, fear, embarrassment, and why should they have a coronary vascular screening? Because of all these things. They have easy symptoms to be missed. Half the women who present with heart attack never had prior warning symptoms. More women than men who have sudden cardiac death have no prior symptoms of any kind of a coronary artery disease or an ischemic heart disease. Women with heart disease and strokes have a worse prognosis than men. And women basically are treated differently when any kind of medical approach is taken. So what is a diagnostic stress testing which is specific for women? As we know, there is a TMT which comes most of the time. There's a false positive reports. So more specific would be an exercise echocardiography, and an exercise SPECT according to the studies, which shows the higher sensitivity specificity ratio here. So what are the symptoms in which the woman presents with AMI? The typical symptoms, as we know, it is a chest pain and discomfort. But additionally, chest pain, it is a pain radiating to the jaws, neck, shoulders, epigastrium, dyspnea, and also associated with diaphoresis and lightheadedness. What is the atypical symptoms, which is shown to be more so in the females who present in the emergency department? They are the sharp pleuritic type of pain, for which mostly it is neglected as that of a cause other than the coronary artery disease. Burning, ache, soreness, and there are other symptoms: undue fatigue, undue shortness of breath, and there is a flu-like symptoms, generalized scared anxiety feeling, indigestion, palpitation, and restlessness, which are the atypical symptoms which the females present in the emergency department, which has to be picked up. So how is the treatment protocols changed from that of the males? It is not the change, it is how do they react to the normal treatment protocol of that of a male compared to that of a female. So all the treatment strategies are the same, but the response to the treatment protocols are vary within the females. Like for example, thrombolytics, the high risk of mortality and bleeding complications compared to that of male in a patient who receives a thrombolytic therapy. PCI is comparatively better off than that of any other mode of treatment as a complete revascularization in patients presenting with acute myocardial infarction. CABG, women having an increased risk of in-hospital mortality or on procedural mortality compared to that of the male. There is what is the treatment in NSTEMI? It is the same. The medical management remains the same. There is no sex variation of changing the dosage of the antiplatelet therapy, though female patients are a little higher risk of getting an ICH compared to that of the male as per the data available. And then even here also the PCI takes the state that it is better to get a patient with STEMI treatment with PCI gives a complete revascularization. Then what is the behavioral interventions which is possible for any ischemic heart disease is a smoking, cessation of smoking, taking care of a diabetes, and referral to a comprehensive cardiac rehabilitation to change in the lifestyle, stress management, appropriate weight management, dietary changes, and physical activity. What are the gaps we had in the AMI having a woman in women? So what is the mortality disadvantage among the women compared to the men? There are many questions which are still have to be addressed. For example, there are unique pathological atherosclerotic manifestations in women, effective intervention and decreasing treatment delays, if in the ethnicity diverse women with AMI, or cause and mechanism and mechanical complications of MI, mechanism by which psychosocial factors influence, most effective intervention and strategies for all these things, relative influence of biological, pathophysiological, and psychological risk factors of coronary artery disease. Most effective, what are the most effective interventions? What are the modifiable factors contributing to the sex disparities in applying evidence-based guidelines in the prevention and treatment? So all those have to be addressed still and have to be researched for a better approach of a patient having coronary artery disease in women. They still give the simple 7 lifestyle changes is to get active, control cholesterol levels, eat better, manage blood pressure, lose weight, reduce blood sugar, and stop smoking. So what are the priorities to improve outcome in women with AMI? Increase awareness of women healthcare providers, polyclinic, policy makers of MI risk, sex-specific symptoms, and clinical presentations. Examine genetic environmental interactions in predicting of early onset coronary artery disease in women. Evaluate the mechanism by which psychosocial risk factors, depression, marital conflicts, anxiety, poor social support influence coronary artery disease development and progression. This is a very important topic to be addressed in the current Indian scenario. Improve methods to diagnose and treat coronary artery disease, sudden cardiac death, and microvascular coronary artery disease in women. Sexual counseling to all women and their partners before the hospital discharge after ACS. The priorities to improve the outcome in women with AMI is the proper pharmacological treatment rates for secondary prevention, implementing effective psychological treatment, development of evaluate novel, adaptive, tailored secondary prevention strategies for women after AMI. So the development of test effective for primary and secondary preventive behavioral interventions that are culturally appropriate for women across the lifespan in variety of clinical and community settings. Develop strategies to increase the inclusion of women of all age groups in cardiovascular clinical research programs. The take-home message for patients having to prevent coronary artery disease and to understand coronary artery disease in women is cardiovascular disease and are amongst the leading cause of mortality and morbidity in women. In recent years, understanding that manifestations and outcomes of cardiovascular syndromes differ between genders has raised. Nevertheless, important issues such as women-specific risk factors, hormonal influences, and different pathophysiological mechanisms have been under research, under recognized, under diagnosed. There is unmet needs for better research, diagnosis, and treatment for improving women's cardiovascular outcome and well-being at a large. Thank you very much.
Thanks, Dr. Hema, for the excellent presentation and taking us through how the CAD is different in women and the way it is being handled by by the doctors, and the way it has to be more emphasized in the society. The gravity of CAD in women. With that, I would like to invite Dr. Neeti for taking us through the heart failure in women and how it is different in women from the perspective of heart failure. Over to you, Dr. Neeti.
Yeah. Thank you so much. Good evening, everyone. Am I audible?
Yeah, you're audible, ma'am.
Yeah. Okay. Thanks, Dr. Mujtaba, and all the attendees. And I'm really sorry about this. I'm sure my video is coming in darkness, but me and Dr. Aparna are at the same venue, so we both are not in a very lighted place. But let me just begin with my presentation. Let me share my screen first.
Yeah. It's visible, ma'am.
Yeah, okay. So women and heart failure, myself, Neeti Chadhanegi. So how is heart failure different in women? So there are certain gender differences which are seen, and the women specific statistic for the heart failure is that women actually develop heart failure at a relatively older age as compared to males. Second, and the most important, is there is a very high incidence of diastolic heart failure as opposed to the systolic heart failure, which is more often seen in males. We will dwell upon the diastolic heart failure more in the coming slides. But for now, we'll suffice to say that the ejection fraction may be normal or more than 50%. But there are symptoms of heart failure, especially the shortness of breath and decreased exercise tolerance and easy fatigability. There is a clustering of risk factors like hypertension. There is valvular disorders, which leads to heart failure. There is a higher incidence of diabetes mellitus. Surely the prevalence of coronary artery disease is lesser in females as compared to males, but that does not mean that coronary artery disease does not form an important aspect of heart failure in females. It actually forms a second leading cause of heart failure in female population presenting with heart failure. So there are endothelial dysfunction and microvascular pathologies which are seen. There are certain cardiomyopathies which are specific only to females, and we'll talk about this later. Peripartum cardiomyopathy is one of them. There are others as well, and we'll talk about this. Overall, the heart failure survival rates are better than males, but these patients, females, stay more symptomatic as compared to males. There are symptoms of breathlessness and fatigability, which might persist, but as such, the overall survival is better in females as compared to males. There are other differences also. The pulmonary artery compliance is lesser in females as compared to males, and they will develop more often pulmonary artery hypertension. Because of differences in body composition, there are differences in pharmacokinetics and pharmacodynamics of the heart failure therapies that are delivered, especially the drugs like beta blockers and ACE inhibitors. So that also needs to be accounted for. Because there is a difference in pharmacokinetics and pharmacodynamics of the heart failure drugs, what we call the optimal medical therapy, that is the guideline directed medical therapy, there is differing responses as compared to males. Treatment wise, these patients are less likely to receive an AICD. Also, there have been studies which have been done which show that overall efficacy of AICD is not as effective as seen in the male population. And they're even less likely to receive an AICD. As far as CRT is concerned, the cardiac resynchronization therapy, They are more likely to respond to a CRT therapy when implanted with as compared to their male counterparts. What the statistics say is that 50% of hospital admissions with heart failure is from the female population, but they are underrepresented in clinical trials, and about 20, the clinical trials represent about 25% of the patient population as females as compared to males. So there is a definite underrepresentation in clinical trials. This is just the number of heart failure trials which have been undertaken and the percentage of women represented in it. The maximum represented was in TopCat study, but overall the representation of female population is as low as 10%, 15%, and there are some studies where no female population was included. And hence, the extrapolation of these heart failure trial data to a female population is not right, and more female representation is required so that the overall therapy can be tailored for these population. Now, the causes of heart failure in females, the ischemic cardiomyopathy is the leading cause for heart failure in male population, but it's a second leading cause in the female population. The other more important causes are hypertension, diabetes, valvular heart disease is very important, especially the mitral valve disease. The therapies which are the cause which is specific to female population, the females presenting with breast cancer and treated with chemotherapy like in anthracyclines, trastuzumab, and other radiotherapy as well, they might develop cardiomyopathy, and this is specific to female population. And also peripartum cardiomyopathy, especially in the reproductive age. This is a specific entity seen in females. So they are also underrepresented in clinical trials. So extrapolating the clinical trial results to this patient population is not lead to effective results. Now, how do you assess these patients? First of all, the medical history. We have to take history of hypertension, diabetes, angina, kidney disease, cancer, etc. You cannot leave a history of smoking and alcohol in female population because there are some patients who will be smokers or take alcohol and develop heart failure. History of past medications, especially breast cancer related chemotherapy or other medications is also to be included. History of pregnancy, recent pregnancy or postpartum history to be taken in women in reproductive age. So this is very important. The blood tests which are to be done for the heart failure population is, they are the usual blood tests actually. So blood sugar, lipid profile, kidney profile, BNP levels, these are to be assessed. Other tests are also usual tests like X-rays, ECGs, echocardiogram, especially the ejection fraction to be done. The overall prognosis of heart failure in women, as we talked about this, the survival is longer in females as compared to the males, but they stay symptomatic and the shortness of breath and functionality wise, they are more limited. But their overall survival is better, require hospitalization more frequently. So this is a risk model. In the heart failure population, the sudden death versus the non-sudden death, the female population will have more incidence of non-sudden death as compared to the sudden death. They might be older in age with higher ejection fraction and as compared to their male counterpart, which will develop heart failure at a relatively younger age and with a lower ejection fraction. They will be less symptomatic as compared to the female population, which are more symptomatic. A higher prevalence of preserved ejection fraction heart failure is seen in female population. So there is a concentric heart hypertrophy, more pronounced diastolic dysfunction as compared to the males, more fibrosis in the heart. They are more susceptible to acute events and flash pulmonary edemas. There is a postmenopausal decrease of estrogen levels, and impaired calcium handling and reduced vasodilation is also seen in these patients. As far as heart failure with reduced ejection fraction is concerned, the females will have a higher incidence of Takotsubo cardiomyopathy and peripartum cardiomyopathy. As far as CAD is concerned, there is a later onset of CAD in these of heart failure in CAD population in females. They will have more atypical symptoms, and the survival is better, but complications and mortality may happen because of the arrhythmias which can happen, and higher incidence of spontaneous coronary dissection and non-obstructive microvascular dysfunction seen in the female population. So basically, the preserved ejection fraction heart failure is the incidence is seen higher in females as compared to males, and there is more fibrosis and more concentric hypertrophy which is seen. So there are several causes which have been seen of why this happens, because of the overall genetic formation in the female population, and there is a smaller anthropometry, so smaller size, smaller build, and the smaller size of the organs also lead to several changes in the myocardial structure and the cardiac metabolism and the calcium handling, which leads to more fibrosis. There are as the estrogen level lowers in the postpartum females, they will also develop higher microvascular dysfunction and endothelial dysfunction. There is higher inflammation, and there is a risk factor clustering which can also take place, like hypertension, diabetes, valvular dysfunction, and they lead to these vascular abnormalities and impaired calcium handling and more fibrosis as compared to males. And these patients will present with heart failure with preserved ejection fraction. This is again the clustering of the risk factors like diabetes, obesity. There is autoimmune disease also. Then the pregnant patients might develop preeclampsia. There is a incidence of hypertension and iron deficiency, which leads to heart failure with preserved ejection fraction. So these are the risk factors which lead to preserved ejection fraction heart failure. This slide again shows that because of all these comorbidities like obesity, hypertension, obstructive sleep apnea, diabetes, physical inactivity, and all, there is an endothelial mesenchymal dysfunction which takes place, and that presents as a heart failure with preserved phenotype, preserved ejection fraction phenotype. There is the echo parameters for heart failure preserved ejection fraction are also given with major criteria and minor criteria. So there is this shows the how do you diagnose is two major criteria. Each major criteria has got 2 points and one minor criteria has got 1 point. So overall, more than 5 points make it a heart failure preserved ejection fraction. And you diagnose it with septal velocities and the lateral wall velocity. The septal velocity is less than 7 centimeters.
May I interrupt, Doc, please? There is a lot of background noise. Could you mute the other participants, please? Mustafa, could you mute the other participants?
Yeah, surely, ma'am.
There's a lot of background noise.
Yeah.
Okay.
So the echo parameters are septal velocities less than septal myocardial velocity less than 7 centimeters per second, lateral myocardial velocity less than 10 centimeters per second. I'll not go through the entire echo criteria, but there are clear major and minor criteria, and each major criteria has got 2 points, minor criteria has got 1 point. When there is more than 5 points, you diagnose it as heart failure with preserved ejection fraction. And between 2 to 4 points, it's a diastolic dysfunction which is assessed. So overall conclusion of the talk will be there are differences in the cause of heart failure because there are less coronary artery disease and more other parameters like hypertension, diabetes, valvular heart disease. So the causes are different. The presentation is even different. There is more shortness of breath and less of the other presentation like angina or rhythm disturbance. Atrial fibrillation can be more in female population as compared to the males. There are differences in test results also. The echo parameters will be different. There will be a better ejection fraction as compared to the male population, and the ECG features will also differ. There are differences in the prognosis. These have got better survival as compared to males. Differences in management because the pharmacokinetics of the drugs is different. Non-sudden deaths are more in females as compared to males, and there is difference in the efficacy of AICD and CRT in the female population as compared to the males. So can we extrapolate the clinical trial data of heart failure to a female population? This should be my final slide. It says that according to Saba Bhatti, this article, is there is a time to treat women differently in the world of heart failure? We have to decide on this and maybe include more female population in the clinical trials. So that should be my final slide. Thank you so much. So
Thanks,
I think we'd like to thank all the speakers. And I think that was a fantastic deliberation by Dr. Neeti, Dr. Rudrani, Dr. Hema. And I think we put up these talks because we thought that this was something which was emerging and the appropriate timeness of this. I would request my co-moderator to please come in and give some comments, and then we'll go into the panel discussion.
Hi, Dr. Jaswal. Presentation by all the speakers. I think if there are no more questions, we are already running late. So should we switch over to the next?
Certainly, Dr. Ritu. I think we'll go into the panel discussion. Yeah. Maybe now invite Dr. Usha Sriram to kindly come in. And I think we have some questions which have been scheduled, and we wish to deliberate on that. So I think I'll request Dr. Usha Sriram to first take on the question about all of us are wanting to learn and know better from her as to what inputs she would like to talk about hormone replacement therapy in women.
Okay, thank you so much. And first, I just want to tell Happy Women's Day to all the absolutely talented, lovely women who are here. Thank you so much. And a real honor to be part of the group of cardiologists who are here. I'm an endocrinologist. So coming to this hormone replacement therapy, this was being done. It was very popular in the, let's say, 60s, 70s, and 80s, largely because of the understanding that the heart health of a premenopausal woman was good, and the heart health of a postmenopausal woman was not good. And the menopause was the defining moment. And we thought menopause equals estrogen deficiency, which kind of it is. So the thing is, you put estrogen back and you get back the health of a premenopausal woman. Sounds like a simple 1 + 1 = 2, but and so it was being done. And a lot of observational data confirmed the benefit of hormone replacement in women. Having said that, then of course, we entered the era of evidence-based medicine, where we had to show everything in a randomized controlled trial. So the Women's Health Initiative was started, which was a large study where they put women on, if they didn't have a uterus, they were only on estrogen. If they had a uterus, they were on estrogen and progesterone. Of course, they were on conjugated equine estrogen and medroxyprogesterone acetate, which was the most popular HRT in the US at that time. So they got put on that, and the study had to be stopped so sort of abruptly halfway, because they found two things happened. One was that there was an increased risk of breast cancer after like 4 years of therapy. And they wanted to answer a very important question: is hormone replacement therapy important for prevention and for care of women who have heart disease? So when that is one of the primary goals they had in mind, and of course there was a big bunch of other things about hip fractures and DVTs and other thromboembolic events, and so this is the global risk as well. So they and cancers, and surprisingly they found that cardiac risk, cardiovascular risk, was elevated in women who were put on HRT. And though we can go into the minutiae about at what age did it happen, and was it only in estrogen plus progesterone or estrogen only, the final report from that study was that we do not recommend HRT as a means to prevent or treat cardiovascular disease in women. And there is this increased risk of DVT and other thromboembolic events. And we know estrogen is prothrombotic or atherogenic as well. Though it did reduce hip fractures, it did reduce the risk of colorectal cancer, and it did things like that, but it did not help them with the cardiovascular question. Subsequently, there have been, post hoc analysis of the same study, and then looking at some observational data. And the final conclusion now is it may be something that can be used for women within the first 10 years of menopause, if there are other indications for HRT, but not beyond that. And of course, we can discuss that later. But the short answer is, for CV protection and CV risk reduction in women after the menopause, it is not recommended. We can take women up to the natural age for menopause, which is around 50, but not for women after that.
Thank you so much, Dr. Usha. I think that really answered the question. And that this specifically came in because I've had in the recent past 2 young women. I say young because I consider all of us very young. Yes. They were in their mid-50s, and they were flying in from the UK, and they were very keen that I put them on HRT, and which probably I don't know if is the practice there, because I could not find any other reason to give them an HRT. So I said, no, as a cardiologist, I don't think I'm going to put you on an HRT. So I think that was very nice, and thank you so much. My other question to you would be, there's something called Takotsubo's disease. What is your thought on that? I mean, how is it that's so unique? Stress hormones, what do they do to women?
So this heartbreak, which really Takotsubo is, if you want to put it in simple terms, is like the heart is breaking. And so this whole, I was so intrigued when this panel discussion title was sent to me, that hormones and the heart, because right now the accusation against endocrinologists is you're claiming every organ as an endocrine organ. Now you're claiming the heart also as an endocrine organ. So we may not discuss, BNP and ANP and all that, which is their hormones produced by the heart. So the heart is also being looked at as an endocrine organ. But the heart is influenced by every hormone produced in the body, be it thyroid or catecholamines or growth hormone or calcium, or parathyroid hormone, all of them. But particularly to Takotsubo, it is, of course, the stress hormones. And they absolutely, not only they have effect on the function of the heart in terms of what happens to the cardiac rate or output and things like that, but actually can cause structural damage. And some of the conditions, like, for example, pheochromocytoma or Cushing's syndrome, and all of them have very stark effects on the structure of the heart, whether it is the myocytes or even whether it's the pericardium, they have effect on the heart. But Takotsubo, definitely the stress hormones play a very big role in affecting the function of the heart.
Absolutely. So I think that was wonderful. Thank you so much, Dr. Usha. I think there has to be something unique to women. And I think most important is that we must finish on time. So I think if there are some more questions, we'll be happy to answer. Otherwise, maybe we can conclude the session.
I think, Dr. Ritu, there are certain questions from the heart failure point of view. If you can navigate us through those questions because we are getting questions on heart failure. How is it different in women, and what is the role of the newer therapies which are there for heart failure? So, if you can ask those questions on and other relevant topics.
See, in the previous discussion of heart failure, doctor has already covered most of those questions. Heart failure being, we just concluded that topic, heart failure in women. So my question to Dr. Usha would be, Dr. Usha, we as cardiologists had always been personally also, and in general in cardiology, we tend to keep our patient either euthyroid, coming to the thyroid hormone, or personally, I would want to keep my patient in a little hypothyroid side, like in a TSH range of 4 to 5. So the classic teaching has been that hyperthyroid can be more dangerous. It would increase the cardiac workload and everything. But there has been a recent study where hypothyroid actually aggravates heart failure risk 2 to 3 times. Your opinion on that? And of course, a little bit of hyperthyroid also, if you can emphasize on.
So you're absolutely right. As far as hyperthyroidism, what we find is that there is a increase in preload, increase in cardiac output, increase in heart rate, and a lowering of the peripheral resistance. All of this happens in hyperthyroidism. But and in hypo, literally the opposite of all of that, and including a component, something like pericardial effusion, which is a big problem in hypothyroidism. But to answer your question, as an endocrinologist also, I would very much like things to be right in the middle. If the TSH is 0.4 to 4.5 is, let's say, normal, I'd like to see the level somewhere around 2 or within 1 to 3, not much lower, because again, it causes a subclinical hyperthyroidism, and that also has got a lot of cardiovascular effects like atrial fibrillation. We recently had an admission in a woman who developed during COVID, and then she had AFib, which was missed, and then when we went back and looked, she actually had subclinical hyperthyroidism. So atrial fibrillation, other arrhythmias, and then very importantly, increased myocardial oxygen demand. So during stressful situations, we can actually precipitate an MI or heart failure. With hypothyroidism, all the opposite of what I just said in terms of cardiac output, or in terms of the peripheral resistance is high, and they usually have a diastolic hypertension as well. Having said that, also, definitely we don't want their TSH to be more than 10. Immediately we are asked to treat people whose TSH is more than 10. Between this 4 and 10, we recommend treatment only for people who have, who plan a pregnancy, are pregnant, or have antibodies and their TSH is rising. It's 5, then it has gone to 7. It's still below 10, but we see the trend to rise and their antibodies are positive. You could think about treating them. But there is a recommendation that if the person is younger, let's say below 65, consider treating even subclinical hyperthyroidism for the cardiac benefits. Right. So this is the recommendation now on treating people with subclinical.
Right. Dr. Usha, one more question. I think you have covered it very well. Regarding this perimenopausal age, we as cardiologists don't get many younger patients of CAD or, otherwise, of course, rheumatic heart disease and device closures and congenital we will get. But this perimenopausal age, the typical 40 to 50, those palpitations, basically we trust on patients' history, if they are like, but we are seeing so many early menopausal, I mean, early onset menopause in the urban population, like patient of 39 would present classic menopausal symptoms. One, are you seeing this trend in endo also? Are these
Yes.
women coming to you so often? And what would you recommend? Most of the times we go by our gut instinct that it could be perimenopausal and try to rule out most of the cardiac reasons for that, But do you recommend any hormonal profile to be done, or do you recommend that before we subject our patients to complete cardiac evaluation, we should be having an endocrinologist on board to guide them through this phase? What would be your recommendation?
Great question. So if normal age for menopause is around 50. Indian women, they say, is around 47. Below 40 is premature, and below 45 is early. So we could be seeing these symptoms, like you said, in those age groups. Now, if they come to us and their cycles are regular, and then they complain of all this palpitations or shortness of breath, I definitely first look at making sure that there's not a cardiac or a pulmonary or anemia issue, and then think of possibly, is she going through this transition? There is a test, the FSH, and also the AMH, but FSH typically, which will rise definitely close to menopause. So if I see an FSH in the menopausal range, it confirms it. But if it's still not in the, it's still in the normal range, it doesn't rule out this menopause transition you're talking about. Right. So one thing we do is, obviously, if they're menstruating, we don't want to give them HRT. We can give them something like venlafaxine, which is now the non-hormonal option for treating vasomotor symptoms, and you could try. And then, of course, stress management and other things. But absolutely right that we want to make sure that we are not dealing with something like a thyroid issue or anemia or stress or a cardiac issue. So this is more by exclusion that we come to this thing. You must be going through the menopause.
Yes. And we see a lot of psychological problems along with, it's not only the vasomotor symptoms, probably it's we see depression so often, anxiety, panic attacks, and after COVID, we are seeing so many women, coming up with these complaints. One more question before we conclude to you, Doctor, or Dr. Parna also could, Dr. Jaswal could guide us on that. Nowadays with IVF and, people getting married late and girls conceiving in third or fourth decade. So late preemies, or people who are conceiving with IVF or etc. Do you think they all should be going through all complete cardiac evaluation? Because I'm seeing so many patients being referred to me just for a screening, the patient is going in for IVF. The gynecologists are nowadays becoming so proactive, especially the ops people, that if they are infertility specialists, I would be getting references that they should be like cleared from cardiac point of view. Is it a pattern all over, or I'm just seeing it in my kind of pocket of the city? I don't know.
Again, a great question. And, cardiac complications have emerged as the leading cause of death in during pregnancy. From all other things, it has gone to this. So I can see the concern of the OBGYNs, why they want this, and the older the mother. And the reason they may have infertility is PCOS, obesity, and things that increase the risk of cardiovascular risk as well. So that may be one. So it's not a bad idea to get a baseline assessment before they get and they're going to use a lot of hormones and things, which some of them can have other kinds of reactions. But you are right in terms of a lot of depression, and we know the connection between depression and heart disease is bidirectional, and so this depression also could be unmasking some issues in the near future.
Right.
Dr. Ritu, there are certain questions from the attendees which are there in your chat box.
So
please.
should I just read it aloud for all my colleagues? What could be the modification in line of therapy for HFrEF with low blood pressure, currently on low dose beta blocker, With ARNIs being recommended after ACE intolerance, do you recommend initiating directly with ARNI or HFrEF if there is a concrete line of therapy defined for mid-range and recovered? Okay, so if you don't mind, can I take up one or two questions and then I distribute it?
Yeah.
Okay. So,
even Dr. Rudra is available. I think she can also intervene.
Yes, sure. Dr. Rudra, would you like to take up this question or should I start?
Madam, you can.
Okay, so Rudra, I'll take this one. I have PrEP with the low blood pressure. We really need their heart rate to go down. Then ivabradine could be a very good choice in such patients. We can still continue with a small dose of beta blockers. We can add agents which are not causing hypotension like ivabradine. And from SHIFT trial, we know that ivabradine also helps in outcome of heart failure. So that is my question to the answer to the first question. Second is with ARNI being recommended after ACE tolerance, do you recommend initiating? Very much. I am in favor of, if you have ARNI in mind, I would say there are guidelines to support that ARNI can be directly initiated. I think most of us would concur on that, rather than first starting the patient on an ACE inhibitor, then giving them 36 hours of clearance and then shifting to ARNI. I wouldn't mind putting my patients on ARNI straight away. If anyone on the panel wants to contribute to that, please feel free.
Basically, madam, you very well said about the hypotension. What I would suggest here is, regarding hypotension, if we are going for beta blockers, I think we should go for the maximum cardioselective beta blocker, and that is bisoprolol. Bisoprolol is the maximum cardioselective among the heart failure beta blockers. That is carvedilol having additional alpha blocking activity also, and metoprolol weaker than carvi and bisoprolol. Here, I would suggest, to prevent hypotension, we should go for a more cardioselective beta blocker, and at present, bisoprolol is the most cardioselective beta blocker. I would agree with madam regarding starting ARNI rather than ACE, because with ACE inhibitors, if you are shifting on ARNI, 36 hours washout is very, very important. You may land up the patient in angioedema if she happened to take even a single tablet of Ramipril or something at her home. This is something very important. At least do not do further harm to the patient. A straightforward ARNI class 1 indication now. I totally agree with Ritu madam regarding this. And regarding what madam said about the SHIFT trial, Professor Baum has very well in his SHIFT trial concluded that to prevent hypotension with beta blockers, we can together start very low dose beta blocker along with low dose ivabradine, because ivabradine working directly on pacemaker current doesn't lead much to hypotension as with beta blockers. What Professor Baum in his SHIFT trial concluded was that together we can go with a very low dose beta blocker added with ivabradine, because ivabradine does not have that much negative inotropic effect on heart.
Right. Very right. So Rudra, another question is mid-range EF or recovered EF. What are the guidelines about RNA? Would you like to take up answer that?
Madam, regarding what I have concluded from peripartum cardiomyopathy when I studied this topic for around about, I think 2-3 days in 3-4 PDFs, what I have seen that because peripartum cardiomyopathy is sort of heart failure with reduced ejection fraction. They have taken less than 45% as the cutoff for making PPCM diagnosis. And what they have concluded in all guidelines from American College and from European societies that in spite of peripartum cardiomyopathy having a very good prognosis, still patient should be very well monitored for even after full recovery. The guidelines say even after reaching 50-55% of EF in next 6 months. What they have said that nearly 60 to 70% patient recover in next 6 months, and still they have given very meticulously working on heart failure with reduced ejection fraction with serial clinical evaluation, serial echocardiographic evaluation, serial troponin BNP levels before even before even diminishing the amount of drugs. And what they have said is doses of diuretics to be taken as low as possible, and these drugs should be very calculatively, they should be decreased, seeing all these parameters. That what I have inferred inferred regarding reduced ejection fraction from peripartum cardiomyopathy.
Right. Very rightly put up. So you would recommend ARNI for peripartal cardiomyopathy, right? If there is no contraindication.
Ma'am, the moment the baby is delivered, ARNI, ACE, ARBs, they can be taken during lactation period along with spironolactones. During pregnancy, all these drugs which I have mentioned are contraindicated. ARNI can be very well taken after the baby is delivered.
Yes. And a word about peripartal cardiomyopathy. Of course, you had touched upon on bromocriptine. My personal experience, though we know it's not, really on label, this is kind of still off label use of bromocriptine. But my personal experience with bromocriptine in all the cases of peripartal cardiomyopathy has been fabulous. Very well tolerated, very cheap drug. And of course, I encourage all my patients to stop lactation. And of course, once they start bromocriptine, it usually stops. So personally, my experience with bromocriptine has been very nice. Do you?
Ritu ma'am?
Yes.
Ritu ma'am, you have said about bromocriptine in a very concise manner. What I have inferred from my studies, from the PDFs I have studied in these 3-4 days, is that bromocriptine in few studies were given 2.5 milligram OD for 1 week, and then 2.5 milligram BD for 1 week, and then for another 6 weeks OD. And it was found to be almost equivalent to rest of the other heart failure medications in relieving symptoms, in giving a good quality of life. Yes. But there are no clear-cut indications till now. But as you already know that it is 2A or 2B indication, that it is all clinicians' consensus. Right. So if you are happy with your patients doing well on bromocriptine, I think one should go ahead.
Absolutely. I think most of the questions we have answered. Mustafa, if there is no more question, we can conclude the session.
Just a couple of questions. One is on the differential positioning of two major therapies which are coming up. One is the SGLT2 inhibitors and the ARNIs. Can you just throw some light on where do you see the right positioning of these two classes of drugs in heart failure?
See, this question is asked in all the webinars or talks I give. I would say my answer to this is there are 4 important pillars for treating heart failure. Beta blockers, ARNI, ACE inhibitor versus ACE inhibitor, SGLT2 inhibitor, and of course MRAs. So they are not competitors. I just don't understand why this conflict comes and why this question is repeatedly asked. First of all, if your patient is diabetic, of course SGLT2 inhibitor has to be there. If the patient is non-diabetic, there is enough data to say that SGLT2 inhibitor has to be there. Now, so I would say yes, both have to be there. Now, the question is which is to be introduced first. There are there is some literature to say, horizontal or longitudinal starting of the drugs. Do we start small? So the consensus about these 4 drugs is we should try to introduce all as early as possible, maybe in smaller dose, and then on subsequent visits, we can probably build on the doses as well. And we should try to get the doses to the real therapeutic range. So both of them are very important. Which one is started earlier, which one is started 2nd or 3 days later doesn't make a difference. We should start all these 4 molecules in the subsequent treatment of heart failure. So,
just last one, ma'am. Is the beta blocker up titration get delayed with the introduction of ARNI, as there could be early improvement in EF?
Yes, at times, Mustafa, but eventually, believe me, most of in India, general, when I see lots of prescription, even with cardiologists and myself included, we do not really see the therapeutic doses being achieved. So, with ARNI, you will see 50 milligram twice a day, half BD, something like that. I would say we should try to quickly build up the dose every 2 to 4 weeks and try to get to at least 100 milligram BD. And most of the Indian patients probably receive 100 milligram BD. They really do not go to 200 BD dose, but 100 milligram BD dose is very well tolerated. And if you are quick enough, you can probably build up that dose in a month's time. Beta blocker, yes, you can, it, as you rightly said, if the patient's blood pressure doesn't go above 95 or 100, there would be a difficulty in stepping up beta blockers. But once they are stabilized on a particular dose of ARNI, you can start working on, after a month, maybe if you have started bisoprolol with 1.25, you can probably go to 2.5, then 5. But yes, we should emphasize on building up the therapeutic doses. So we should try to go to 5 milligram of bisoprolol or more than that. And we should try to go up, on even in ARNI as much as tolerated. And most of the patients tolerate, believe me. We shouldn't be scared of, jumping onto the higher doses.
Yeah, thanks a lot, Dr. Ritu. Already we have exceeded time.
Ritu ma'am, here I would like to add one thing. Basically, whenever you are introducing these drugs always keep an eye on your diuretics dose.
Yes.
What people I have seen in prescriptions of physicians, what they do is they keep the dose of diuretics somewhat like Diator 20 milligram going, and then ARNI 50 milligram. If you ask the patient, are you dyspneic? The patient will say, no, I'm not all dyspneic. Are you having inadequate urine output? No, not at all. That's what I am seeing in practice of physicians, that they never reduce the dose of diuretics.
Yes.
When you are putting a patient on dapagliflozin or you're putting them on SGLT2 inhibitors, you have to reduce the dose of diuretics, and you have to build up the dose of bisoprolol, or you can say the beta blockers, then ARNI. When you reduce the dose of diuretics, then only you can build up these drugs, because diuretics, they just relieve the symptom. They have got no mortality benefit in any of the trial. What madam has said about the 4 pillars, all 4 have got the mortality benefit, and this should be given to the patient of HFrEF, and provided you keep an eye on the usage of diuretics you are giving to the patient.
Yes. Since we just mentioned HFrEF, a word about HFpEF, Emperor Preserved Trial. I mean, it's probably one of the first drug which could give us some benefit in HFpEF. We used to feel so helpless in treating HFpEF, right? So after this Emperor Preserved Trial, we can be, at least we are giving something to the patient, tell you, no? So
and
I think we can.
Is that a significant patient population, Dr. Ritu?
A large population, as rightly covered in our lectures also. Women with diastolic dysfunction, but we used to call them in HFpEF patients, a large population, Mustafa. They are underreported, they are undertreated, they are taken very casually. They are considered psychiatric patients. Believe me, the thought always comes to our mind when we are treating such women. They would say, "Dam lagto, poor women," and we would just say, "No, there is nothing." But yes, it is underreported and undertreated. It's a large population, believe me.
Yeah, thanks a lot, Dr. Ritu. We have already taken a lot of your time, exceeded your time. Thanks for your expert opinion. It was really helpful. I would like to give it to Archis for closing the meeting.
Yeah. So thanks, Mustafa. I am Archis, all madams, correct? Archis, I head the division, and it's so nice to see all, highly educated, graceful women. And see, today I really felt, to the record, we generally record programs, but I think this recording will be, really useful. If we play this, there was never so much, specific discussion on heart failure, and that too into women, and that too, a completely never ending questions coming in that. Right now also I got a message from my colleague is that, boss, for a few more questions are coming, but we'll have to force stop, somewhere. So I think Indian tradition treats women as very auspicious. If so many auspicious hands they join for heart failure, I think this failure can become success. It won't remain, as hard failure thing. Somewhere, it can come as a success. We very sincerely thank, all the graceful lady doctors from DRL point of view. Thanks for joining with us, and happy Women's Day once again to all of you. Thank you.
Thank you, Archis, and thank you for connecting all of us. It's so good to connect with all my beautiful colleagues. Thank you so much. Thank you for having me.
Thank you.
Dr. Usha Sriram, when I was long back, I was in some other company, I was struggling in diabetes. That time I met you, and you helped me and guided me in my career, and that time for developing diabetes also a lot. Correct. So you may not remember me because there are so many people you guide like that, but it
do
helped me a
remember.
lot. Thanks.
Do remember.
Thank you, Dr. Usha. It was so good to hear from you.
Yeah, thank you. Likewise. Thank you.
Okay. Good night.
Yeah.
Bye-bye.
Good night, ma'am. Good night, ma'am.
Yeah. Thank you. Thank you. Bye. Good night. Yeah.
कैसा बोला मैंने देखा